Like Jordan told you guys, my name is Katie. I graduated from here in Fort Hays in 2002 with my bachelor's degree in nursing. I'm currently working on my master's in nursing education. So as a requirement for one of my classes, I have to come teach a class. And since I've done most of my nursing career, plus some in cardiology, Jordan let me know she was teaching about some cardiac stuff today and gave me the opportunity to come in, so I appreciate you guys letting me come in. So today we're going to talk about coronary artery disease. And coronary disease is basically when the arteries that supply the heart muscle build up plaque and are unable to adequately supply the heart muscle with blood supply. It is the single largest killer of American men and women. A lot of people think that cancer is number one, but heart disease actually outranks cancer, and as well as the leading cause of premature and permanent disability in the United States. Some of the risk factors associated with coronary disease are obesity, smoking, hypertension, and high cholesterol. There's also a few other ones, diabetes. Can anybody think of any other risk factors for coronary disease? Non-modifiable risk factors, age, gender, family history, and ethnicity. These are factors that you are not able to help patients modify to decrease their risk of coronary disease. So arteriosclerosis is actually the thickening or hardening of the walls of the arteries. If you think about like a garden hose, when you first buy a garden hose, they're nice and stiff, they're flexible, you can bend them, they have a little bit of stretch to them. As we age, people that smoke and diabetics, oftentimes the wall of the arteries becomes stiff and hard, they're not flexible, and they don't give that stretch like a nice healthy artery does. And atherosclerosis is when that plaque builds up in the artery wall. And a lot of times, I know when I first started as a nurse, I always thought that plaque built right against the artery wall. It actually builds in between the artery wall and kind of a lumen, so it's got it in a sheath in the artery wall there. I'm going to talk really fast, you guys. I'm sorry.
You're doing good.
Bear with me here. Thanks. So after there's damage to the artery wall, or it starts to develop that plaque in there, the vessel lining actually becomes inflamed, which causes an increased buildup inside that lining of the artery. And your plaques are either stable or unstable. Your stable plaques are usually a fixed plaque. Unstable plaques are prone to rupture. So those are the lesions that we're typically worried about when we're doing cardiac, because those lesions can rupture, which then stimulates the body to attack that area. So then you've got platelets forming at that area, which causes a blood clot, which can then completely occlude that wall of that artery there. Again, we've got the risk factors listed. Diabetes is on there, metabolic factors, smoking, family history, diet and exercise is a really big modifiable risk factor for heart disease, and as nurses that's typically one of the biggest things that we educate patients on is diet, exercise, and then smoking, as well as cholesterol management. Treatment for cholesterol management, obviously healthy eating. You want to encourage patients to eat a diet low in cholesterol and saturated fats. Increasing fiber and good dietary fiber is a big key factor. And not one that we think of very often, and of course eating fresh fruit and vegetables. Oftentimes patients are prescribed medications to help treat their hyperlipidemia. Statin medications are used, and those really help stabilize those lipid, that buildup of fatty tissue in those arterial walls. A lot of times in the hospital we'll have patients that are on statins and their cholesterol levels are fine. But if we've got patients with unstable plaque lesions, we usually will put them on a statin just to help harden and stabilize that plaque lesion. Fibrinic acids are used to increase HDL, which is the good cholesterol, and decrease LDL. Hold on, I gotta catch up on my notes. And then Zetia is usually used in combination with statins, and then the PCK or PCSK9 inhibitors are actually an injectable cholesterol medication. Patients take those twice a month, and they actually work really, really great, but they're super expensive, $300 to $400 a month. So a lot of times that is not an option for patients, even though it's one of the best treatments out there for lipid-lowering agents.
And then I need to go skip all of these PVD ones there. Just keep looking. You can use the curve in there too.
And then I'm going to just jump here over to stable angina and skip the PVD stuff, and we'll come back to that. So angina is chest pain. It's usually described as classic chest pain symptoms or angina symptoms are going to be patients that present with chest pain, chest heaviness, shortness of breath, diaphoresis or excessive sweating. It can be either stable angina or unstable angina. Typically, angina occurs with a moderate amount of activity. And if it's chronic stable angina, it doesn't always have to be treated. Typically, those symptoms will be relieved with rest or nitroglycerin. So if your patient comes in and they have had chest pain, you want to know what were you doing when you had the chest pain? If it's, were you walking to the mailbox? Did you run 3 miles? And what made it better? So what makes it worse? What makes it better? And what'd you do to make it go away? Like I said, some of the symptoms are chest pain. A lot of times that pain will radiate up into the jaw and neck or down the arms. A lot of times it's the left arm. Patients are short of breath, they're nauseated, fatigue, weakness, and the excessive sweating or diaphoresis. Unstable angina presents very much like stable angina. However, it's usually not relieved with rest or nitro. As far as dosing of nitro, it always comes in 0.4 milligrams, and it's a sublingual tablet they just put under their tongue and it dissolves. Nitro helps to dilate those blood vessels and gets more oxygenated blood to the heart tissue, which helps decrease those symptoms of chest pain and angina. So unstable angina, like she's got up there, these attacks last longer than 15 minutes. A lot of times when patients rest or take their nitro, it doesn't go away. And these are the patients that need, this is a medical emergency, so you want to get them to the hospital as soon as possible. These patients typically are going to have an EKG and have lab work drawn. Troponin and cardiac enzymes are specific to not just myocardium, but actually all muscle tissue. So when we draw these labs, oftentimes if there's other muscle damage in the body, they can be elevated, but troponin is specifically a cardiac marker. So if your troponin is elevated, then there's probably some damage to the heart muscle at that point in time. When you're doing clinicals, you may hear them talk about a troponin bump, and that's what they mean, is that cardiac marker in the blood is elevated. And then the American College of Cardiology standard treatment for chest pain is the acronym is MONA. Morphine, does anybody know why we'd give morphine to somebody that came in with chest pain? Breathing. Pain, relieve pain, help relax, because oftentimes patients that have chest pain come in, they're very anxious and upset. So morphine, we give it for pain control as well as just to help them kind of relax. How about oxygen? Anybody know why we do oxygen? So the reason the patient's having chest pain is because their myocardium isn't getting oxygenated blood. So we try and front load a bunch of oxygen to try and get them as much oxygen in their blood circulating as possible to try and keep those tissues oxygenated. Nitro, like I said, helps to dilate those blood vessels and increase the amount of blood going to those tissues. And then how about aspirin? Why would we give a patient with chest pain aspirin? That's right. So it's going to keep that blood from clotting, and if there is a narrowing in an artery, it's going to keep the blood moving and keep it from occluding that vessel. Women that present with angina oftentimes don't have the classic symptoms of chest pain and shortness of breath. A lot of times they come in and they're just tired. They've had indigestion, they have pain between their shoulder blades, they've just been tired. So you have to, when you're assessing women that are coming in with symptoms like this, you really kind of have to try and pick through their symptoms to decide if it's cardiac or if there's something else going on. Like I said, nitro can be taken. It's 0.4 milligram tablets. That's typically sublingual. Goes under the tongue and it dissolves. They can take up to 3 doses once every 5 minutes. If they've taken 3 doses of nitro and they're still having the pain, we always tell our patients that call in that they need to go to the emergency room. We always tell patients never to drive. You call 911 or you have somebody drive you. Oh my God, and that's it already. That was so fast. Does anybody have any questions about coronary disease? I actually have a couple of things I wanted to bring and show you guys today. Just a model, kind of shows you a healthy artery and then how the plaque develops and starts to occlude the artery. And then I haven't really talked to you yet about treatments or how we diagnose coronary disease, but I guess I can do that right now while I'm passing these things around. So here's the artery. And then this is a stent. Typically, our patients come in with chest pain, we'll do an EKG. If they're stable, we may just recommend a stress test. There's several different types of stress tests that we can do. One is called a stress echocardiogram, which is, we use ultrasound actually to check the heart wall and muscle. So we'll hook patients up to an EKG machine. We will use the ultrasound to look at their heart muscle at rest, and then we will put them on the treadmill. Treadmill starts out nice and slow, starts to go a little steeper and a little faster every 3 minutes until we get them to a target heart rate. Target heart rate is usually target heart rate is determined 220 minus the patient's age, and then you take that times 85%, and that's how you get their target heart rate. So you're going to leave that patient on the treadmill as long as they can tolerate it to that target heart rate, or until they tell you they cannot run on the treadmill anymore, because the incline also goes up every 3 minutes. So once you get the patient to target heart rate, you usually push them about another 30 seconds because you're going to have to get them back to the table to re-image them. So we'll get ultrasound images of the heart after exertion. And then what the physician does is he takes the pictures of the heart at rest and the heart stressed and looks for any areas of the heart muscle that isn't squeezing adequately. And then we can also do a nuclear stress test, which is basically the same thing, except we actually inject a radioactive isotope, which targets heart muscle cells, and then they take pictures under the nuclear camera. So if the doctor does see an area of the heart muscle that is not uptaking that adequately, next step is the cath lab. And I don't know, will these guys get the chance, probably not this semester, to go to the lab?
Not this semester.
So the cath lab is where the physicians do put in their coronary stents. So the stent I'm passing around is not a coronary stent. They are a lot smaller. However, that was the only stent I could find when I went up to the clinic. But it's the same basic concept. It's just a mesh wire object that is collapsed down over a catheter. The physician can go in either the wrist or the groin, and they thread that catheter up into that area of the heart where the lesion's at. They actually first inflate a balloon and kind of push that plaque against the artery wall, and then they insert the stent and pop the stent open. And so just by pressure alone, that stent holds that plaque against the artery wall and allows blood to flow through there. When the stents first came out, we had a lot of patients that came back in that had re-occluded, because your body's natural instinct is to occlude off a foreign body or start clotting. Now we have drug-eluting stents, which actually are coated with medication that keep that area from clotting. So that's
And they're usually on
coronary. And then we do place patients on not anticoagulants, but like a Plavix or an antiplatelet medication, Plavix and aspirin, to keep those platelets from aggregating.
It's usually a year.
Mm-hmm.
After.
For PCIs, it's a year. Yeah. Peripheral is usually 6 months. So. I know that was quick and dirty on coronary disease. You guys have any questions on that? They're so quiet.
Mm-hmm.
I brought a couple other things just to kind of show you guys while we're talking about the heart that we do up at the hospital. This is actually a pacemaker. I don't know if you guys know anybody that has a pacemaker, or if you'll ever get the chance to take care of a patient with a pacemaker, but this is what a pacemaker looks like. And this is actually an internal cardiac defibrillator. It's a lot bigger because it's got a lot bigger battery in it, just because it takes a lot more energy to shock somebody than it does just to pace them. So peripheral vascular disease is just kind of a generic term that encompasses both arterial disease as well as the disease in the venous system. Basically, it's any issue that alters the way that the blood flows through the periphery. Peripheral disease isn't just in the legs. We also consider carotid disease, peripheral disease, patients that come with any type of subclavian stenosis, that's also considered peripheral disease. Stenosis of the aorta, plaque that builds up in there is also considered peripheral arterial disease. So it's not just the legs, even though that's typically the examples that we present. Peripheral arterial disease is obviously a disease in the arteries of the periphery. And the pathophysiology for that is a lot like coronary disease. That plaque builds up in between that lumen in that artery, causing a decreased blood flow. Symptoms of arterial disease. Usually these patients have disease quite a while before they realize what's actually going on. But when they do come in, they're going to start complaining of burning in their leg, numbness or tingling. And again, with these patients, you want to know, what were you doing last year that you can't do this year? Can you walk a block? Can you walk 2 blocks? How far can they go before they start having symptoms? And then what makes it better? Does it go away when they rest? If they stop walking, does it go away and they can resume their activity? In addition, you want to know where exactly they are having the claudication symptoms. Patients with occlusions higher up in the leg are going to have hip and buttock pain. Patients with occlusions lower down in their leg are going to have more of the numbness, tingling in their calf and foot area. And then she's got intermittent claudication on here, and that's what we call it when they have leg pain until rest, and then when they rest it goes away. As far as assessing peripheral arterial disease, stage 1, like I said, patients are asymptomatic. They don't even know they have anything going on. Stage 2 is that intermittent claudication where they have pain with activity. Stage 3 is pain at rest, and a lot of times they describe it as numbness and burning. Oftentimes they have that like while they're just sitting in their recliner in the evening, they'll notice it, and then they'll report that to you during your assessment. And then stage 4 is necrosis or gangrene. A lot of the patients that we see come into the clinic with this are actually being referred back to us from wound care. And then we have to go in and open those little vessels with stents or balloonings to get good blood flow to help those ulcerations heal. The inflow disease, those higher up vessels are where you're going to get that discomfort in the lower back and buttocks, like I said. And then outflow disease, lower down, usually below the knee, the popliteal area, and that's when they get that discomfort lower down. So if patients come in with these kind of symptoms, typically in the office, we check pulses. We do a quick skin assessment, look for breakdown, look for ulcerations, look at skin color and temperature. And then oftentimes we'll do what we call ABIs, which are ankle brachial indices. And that's why Jordan wants to go grab the blood pressure cuff. Do you want to demonstrate that now, or you want to do it at the end? End? Okay. So like I said, you're going to monitor pulses in both feet. If you have a patient that you're having difficulty finding pulses, I'll recommend you grabbing a magic marker, a permanent marker, and actually Xing over those pulses. So next time you go back, it doesn't take you 10 minutes to find the pulse. You know where it's at. You can check it right away. Like I said, we always check for ulcerations. Patients with chronic peripheral disease often have a lot of skin changes, so their skin is dry, it's discolored. Their toenails get really thick and crusty, and a lot of times they come in, if they've had a cold leg or occluded for quite a while, their skin's going to be kind of cold and mottled. But they also, you see how that one leg is really red, they also may have some dependent rubor or that redness, which is kind of just a flushing in that extremity. So interventions, our peripheral interventions are very similar to the coronary interventions. Our goal is just to increase circulation to that area. We always try non-invasive interventions first. You want to tell these patients to walk even though it hurts, because the more they walk, they're going to develop collateral circulation. So although those big vessels might be occluded off, that demand is going to cause the body to start developing other pathways. So they're going to get little branches of small arteries that are going to start feeding those areas. So even though patients complain about it hurting, you always want to encourage them anyway to continue to walk. Have them walk until they start to experience the pain, tell them to stop and rest, and then continue again as long as they can. Drug therapy, a lot of times we put patients on the same medications as we do for the coronary occlusions, and that'd be the Plavix and the other non-platelet inhibitors. And then if other treatments fail, then of course we go to the angioplasty, which is the ballooning or the stent placement. And you can put stents anywhere. We can do legs, you can put a stent in the aorta, you can do stents in the carotid arteries, really anywhere that there is an occluded artery. As long as you can get a catheter through that occlusion, typically they can fix it with a stent. If we can't fix it with a stent, if it's there's too much disease, if it's the whole length of a vessel and we have to do surgery, there's surgical options. The cardiac surgeon we work with does peripheral work as well, so he can actually do a bypass. He does bypasses from the axillary all the way down to the leg. You can do like the femoral artery down to the popliteal artery, or the popliteal down to the tibial in the foot. So there's other options if patients aren't able to, if the disease is so large that they can't fix it with a stent. As far as nursing care, post-stent placement, you're going to observe for bleeding. Usually with a peripheral stent, they go in the groin. It's a larger vessel. For coronary arteries, a lot of times our docs can go in the wrist because they're smaller vessels, but the leg vessels are a lot bigger. So typically they'll go in the groin to feed that catheter down to the lesion. So you're going to watch for bleeding at the site in the groin. You're going to monitor distal pulses, and again, like I said, you may want to mark those with a black X so you can find them faster. Otherwise, every time you go in to assess that patient, it's going to take you 10 minutes to find that. Monitor vital signs. And then your expected outcomes, you're going to warmth, redness, and edema. A lot of times these patients, once they start getting reperfused, have a lot of discomfort and pain in that extremity. And a lot of that's because that blood is flowing back down to the leg, the nerves are waking up, and they are having a lot of nerve pain. And then monitor for signs and symptoms of hypovolemic shock, which is just low volume, so they're going to have a decreased blood pressure, increased pulse. Their urinary output will be going down. And then for an acute arterial occlusion, here Jordan has listed the 6 P's of ischemia: pain, pallor, pulselessness, paresthesia, paralysis, and coolness. You go ahead and try
I
and
always
say
make them try and say the hard words. I'm pretty sure I said it in their in my lecture. I was like, points for anyone that can say that word on Friday.
that. Would you know if they said it right?
No.
Oh, okay.
I have to Google it and have Google tell me how to say it.
You Google a lot of stuff.
Yeah.
So these patients typically come in through the ER. If they call the clinic with any of these symptoms, usually we'll say just go to the ER as well. So they come in. These people have, their extremities are white. There's zero color. They don't blanch. There's no blood flow into these extremities. A lot of times the patients, like it says, paresthesia, they can't feel the extremity. They can't move the extremity. So these are also a medical emergency. These patients typically go to the operating room right away, where we do a thrombectomy, which is where you go in and actually grab that clot and pull it out, and then a stent or a bypass to get blood flow reestablished to that area. If you don't get those treated, oftentimes patients, it'll lead to limb loss. You actually have to amputate that extremity, because if that tissue goes without blood flow long enough, it's going to start dying off, so it's unsalvageable. So blood clots are our next slide. So venous disease causes blood to back up into the distal areas and can lead to edema and thrombosis. Oftentimes patients that have, not oftentimes, but occasionally patients that have DVTs can develop an emboli. So part of that blood clot breaks off, and it actually travels up the venous system back to the heart, which can cause a heart attack, or even the brain, which could cause stroke. And a DVT is the most common type of thrombosis that the body develops. A lot of times you'll see those in the legs. They tend to develop swelling and redness. They have localized pain in the area of the clot, and then the extremity is usually warm. You can see that leg on the left there is like twice the size of the other one. It's kind of pink. So risk factors for developing thromboembolisms are trauma. The biggest one that I see are patients that have had a pelvic fracture, a hip fracture, and they are immobilized for a long amount of time. They're not able to get up and walk, so they just lay there in bed. Patients with different types of blood disorders and cancer may be more prone to developing blood clots. Our post-op patients that you guys are going to be taking care of, you're going to notice that physicians want them up and moving, even the hips and knees, and people that are non-weight bearing, and that is just to get them up and moving and get those muscles contracting and getting that venous return back up to the heart, so that blood isn't pooling down in the lower extremities. So when you're doing your assessment, you may notice that your patient's complaining of calf or groin tenderness. If you're concerned at all about a DVT, you'd want to talk to the physician. Typically, they order a D-dimer, which is a blood test that will indicate if a patient is developing a DVT. And then we proceed on to an ultrasound of the venous system, which again just shows if there is clot developed in that area. As far as nursing interventions for an embolism or a thrombus, which is kind of funny, because I just told you always want your patients up moving. But once a patient does develop a DVT, then they're at risk for producing an emboli. So you do want them to rest that extremity. A thrombectomy is when the physician actually goes in with a catheter and will kind of go in and snatch that clot and pull it out. And then IVC filters. If a patient has chronic DVTs or has thrown an emboli, a lot of times cardiology will go put it in an IVC filter, and they do it a lot like they do a coronary stent. They go in the groin, and then they will thread the vena cava filter up into the vena cava, and it actually is like a little basket or a mesh umbrella that sits in the inferior vena cava. And when those blood clots pass up through that, it catches it before it gets to the heart to prevent blood clots. So it's meshed, so regular blood still passes through, but it catches those blood clots. And typically these patients are on either IV heparin or sub-Q Lovenox, and so those clots will get broken down. They won't stay caught in that basket forever. They'll start to break down, and the body will reabsorb them. These patients are put on warfarin. Have you guys done pharm? Yeah, they've had some pharm. So you know that that's a blood thinner. And then thrombolytics. A lot of times if there's a localized clot, they may even go in and do like some TPA. So they'll put a catheter in and go to the site of the clot, drip TPA, which is a clot busting agent, and break that clot up that way. The NOACs, the novel oral anticoagulants, are newer medications, and they basically work a lot like warfarin, but they don't have to monitor their INR on a monthly basis, weekly basis, depending on how. Everyday basis, right. And at the bottom there, she's got monitor bleeding in labs. So with the NOACs, you don't have to monitor labs as often. Sometimes we'll check a CBC every once in a while, but the warfarin, you do have to check an INR, and we like to do that at least once a month. If they're on IV heparin, depending on how fast your heparin rate is, usually we'll check PTT. She's got the normal range up there of 50 to 70 for a PTT. Therapeutic INR for a warfarin patient is 2 to 3. And she's got limit vitamin K up there. Can anybody tell me why you limit vitamin K in a patient taking Coumadin?
Vitamin K is a clotting factor.
There you go. So it works against the warfarin and decreases the effectiveness of the warfarin in the body. A lot of times we'll give IV heparin or the sub-Q Lovenox or enoxaparin until the patient's INR is therapeutic on warfarin, and then we can discontinue those. And then as far as prevention for venous thrombosis, patient education, again, that's you want to let your post-op patients know. That's why you need them up and walking, is to prevent blood clots. Leg exercises, so if they are immobile, helping them do as many exercises in bed, or teaching them how to do some exercises in bed to keep them moving. Early ambulation post-operatively, adequate hydration, compression stockings, which everybody hates TED hose, nobody likes to put them on, but they are actually really important, and that just helps increase that venous return back up to the heart. Same with the sequential compression devices. Once you guys take care of some post-op patients, you'll see patients wearing these, and they just kind of pump up and relax, and that's just to help increase that venous return and squeeze that blood back up to the heart. I have no idea what a venous plexus foot pump is.
I think it's a different type of SCD.
All right. Then there's anticoagulation therapy on there again. So venous insufficiency is also in the category of venous or vascular disease. These patients are usually patients that have worked on their feet. They stand on concrete. A lot of times I see nurses come in with venous insufficiency. So always wear your TED hose, your compression stockings once you guys hit the floor. So what happens is these people are on their feet all day long. Blood tends to pool because of gravity, and venous return is decreased, and so they start to get varicose veins. I'm sure you all know somebody with big bulgy varicose veins, and that's just because that blood started to pool down there and is stretching out those veins. You'll see some of these pictures, the patient's skin is really dark. Those are hemosiderin deposits. It's actually the iron is kind of leached out of their blood and stained the skin. So that's why people with chronic venous insufficiency have that dark skin color around their ankles there. And typically with these patients, you're just managing symptoms, because by this time there's not much else you can do. Again, wearing compression hose, elevating their legs above the level of their heart when they're at rest. If they sleep flat in bed, we usually tell these patients to put a couple pillows under their feet just to prop them up. When they're sitting in recliners as well, we have them prop their feet up on pillows. Drug therapy, I don't know of a lot of drugs that we prescribe for venous disease, other than if they start to develop some small superficial clots, sometimes we'll put them on an aspirin or anticoagulant just to keep their blood thin. And then surgical management, in the clinic we did a vein clinic, so we would go in and actually do phlebectomies, where we would cut out those large ropey varicosities and then just suture them off, because they're not efficiently returning blood to the heart, so there's really no point in keeping those around. Patient teachings for venous insufficiency. Talk to your patients about ways to prevent DVT and then prevent recurrent embolism. When patients have venous insufficiency, talk to them about the bulging in the veins, those varicose veins, how to take care of the swelling, the edema, by keeping their legs elevated. If they do start having the itching, the pruritus, a lot of times we'll just let patients know to get over-the-counter lotions to help with that. Identifying signs and symptoms of venous insufficiency. And then, like I said, their legs should be elevated above the heart when they're in the bed or in a chair, and having them wear their TED hose.